You look familiar.
Oddly, I look familiar to me too. In fact, I just saw myself in the mirror. You look familiar. Good morning, dear Dr. Rosensweet. May I welcome you to our show.
Yes.
Can you move over just a little bit? Because I'm seeing a quarter of you. There you are. Okay, that's the familiar man I know. Welcome to all the women coming in. Dr. Rosensweet has informed me he has a super uber hard stop at about 10 minutes too. So we're just going to jump right in. Question number 1. You ready?
I'm ready.
All right.
Sock it to me, Carolyn.
That's right. We the women got the power and the men. All right. So, questioner writes in, hello, I am new here.
Sorry.
That's okay. I am new here and I have blood clots. Ouch. May I use creams or injections? I have been told to use pellets for testosterone, but I'm scared to try them. Once they're in, they don't come out. So I'm a little bit confused here. Can you shed some light, please?
Yes. That's my answer.
I think it's a great answer.
Oh, do you want the light?
Please, a little light.
Number 1, although I have heard discussions that around pellets that I'm open to, in general, I am a non-fan of pellets. So I always want to give you my best shot. I always want to tell you what's so from my perspective, and I would not recommend pellets. Caveat, I have talked to providers that have taken great care to learn how to do pellets, and they're usually doing lower dosages. And so I'm not going to, and I know I would suspect in the hands of someone who really knows what they're doing and has had a lot of experience with it, pellets could be an option. They're just not something I can imagine myself ever recommending, especially with topicals.
Well, this woman is saying testosterone only.
Yeah, I did hear that. But I want to give you, I'm coming in backwards. I'm leading with, I'm not a fan of pellets under almost any circumstances. And then, there's physicians who will debate this with me. Now, blood clots. Let's talk about them. And these are real phenomena. I mean, where did I first learn about them? That when birth control pills were being prescribed absolutely massively, some of the most popular prescription drugs of all times, there was a small number of women who would get a blood clot. These are young women. They get a blood clot in their legs. It elicited inflammation, is known as thrombophlebitis. And on rare occasions, but it did happen, those blood clots would break loose and they'd go to the lungs. And that's called a pulmonary embolus, and that can be life-threatening. Rare? Yes, but it definitely happened. And that was tracked down to, and there's a lot of medical literature showing that this was about oral estrogens. Oral estrogens taken by mouth. Because of that and other reasons related to estrogens being given by mouth, I am 100% non-fan of giving estrogens by mouth, especially when topical estrogens, those that you apply to your skin or mucous membranes, do not have that complication. Part of the reason is just when you deliver something by mouth, you got to do higher dosages. They take a first pass through the liver. But whether we understand the mechanism or not, we are very well aware that in some cases, oral estrogens taken by mouth, can increase the propensity of the blood to clot and thus lead to blood clots intravascular and even emboli. And they also increase inflammation. So I can't think of a reason in the world of ever giving estrogens by mouth. Oops. In my 50 years of being a doctor and 25 years of treating women in menopause, there wasn't one exception. It was my own mother. She finally was willing to let me treat her for the challenges she was having, in her late 80s, and she had enough cognitive challenge that she could not deal with topicals. So she needed a pill. So I did give her oral estrogen. So you never say never in medicine.
Right.
My own mother.
Aww.
Only oral estrogen I've ever written. Now.
But it helped.
Yes, it did. Now, there's more to this story. I've also had patients that were different than the theory that it's the topical estrogens do not cause increased coagulability. Nancy and Denise, I remember them well. And they were women when they had thrombophlebitis, and one of them had a pulmonary embolus when they were very young on the birth control pill. Well, now they're revisiting hormones when they're menopausal. And I did what I always do. I prescribed topical hormones to them. And lo and behold, each one of them said this to me: I'm feeling a little uncomfortable in my legs like I did when I took the birth control pill. And that was the beginning of the thrombophlebitis. We stopped the topical hormones. They went away. We restarted them. The pain returned. We eventually found a way to treat them topically. But what this did for me was this. It made me burrow deeply, deeply, deeply into the world of coagulation, because the issue here is coagulation. And indeed, some human beings have a propensity to coagulate more readily, in fact, possibly excessively, than other human beings. It's called coagulopathy. And there's reasons for coagulopathy. There's a lot of them. Birth control pills was one of them. Increased propensity to clot. Infections can give increased propensity to clot. Oddly enough, the coagulation mechanism is one of many, many, many phenomenal ways that we're protected from germs.
Right.
We coagulate them. We throw the coagulation mechanism around them like a net, like a fish net, so to speak. Tie them up. Well, there's laboratories that have taken on the project of assessing an individual human being's propensity to coagulate. Now, almost every trained physician knows the simple tests, ProTime, PTT. There's simple stuff, but the esoteric stuff around coagulation is known by not very many. And there's definitely hematologists who know this. And through traditional labs, like the ones that are most popular in the United States, we can access these sophisticated tests to assess coagulation. And this derives from, when you look at the physiology, the physiologic biochemistry related with blood coagulation, it is absolutely staggering. By the time I was a senior medical student, my head was so full of so much information, it was about ready. My hair was standing on end permanently.
I've seen pictures and I can attest to that.
And then as a senior medical student, they waited to introduce us to the coagulation biochemistry. And oh my God, there was just 100, I don't know, it looks like there's about 30 moving biochemical parts. And so in order to truly assess coagulation, one needs to understand every one of those things, including some genetics, because there's some genetic increased propensities to coagulate. No problem. There's a laboratory both big laboratories now have direct access to the multitude of tests one can do. And even yesterday, I was speaking to the coagulation expert at one of the laboratories, because in the last month, I've tested 3 of our potential patients for their propensity to coagulate. Why? Because one of them had a stroke at one point because of a coagulation issue. So before we wanted to treat her with hormones, we wanted to see, did she have an increased propensity to coagulate? And we learned that she did not, through a very sophisticated and expensive test. And we're going to retest her once we give her the hormones. What am I saying? There's always a way in medicine. There's always a path to figure this stuff out. And when there is history of propensity to coagulate increased, we just address it. So I'm going to say that the original question you asked was, should you not be taking hormones, especially estrogen and progesterone? My answer is, you should be taking hormones. And you're as good as anyone to take hormones. And how we proceed in the menopause method is we do a very, very thorough history. It takes quite a while for a woman to fill out the questionnaire. And when we look at that and we look at what other testing you had done, and we come up with an evaluation about what we think we should do next. And usually with people who have clotting issues, we're going to test you first. And if you've had past coagulation issues, it's quite likely that if you have insurance, it's going to cover it, because the diagnosis of heightened coagulability exists. So we can just put that on the lab requisition. So I think I covered all of that question. Did I, Carol?
Indeed you did. Okay, indeed good. You did. And very well, I might add. Bravo. Thank you. I'll get to those questions. I'll get back with you guys. I acknowledge you and see you and welcome you. Facebook users. No names. Okay. All right. Could you please clarify how SHBG, which stands for sex hormone binding globulin, affects how hormones work in the body? I am wondering if my SHBG, questioner is saying, could be high related to my taking higher doses of hormones due to how it is I have chosen to dose, which is with rather high doses of estrogen, which I will not do anymore.
I love this question, and I am aware that it pops up periodically and for good reason. Yes. For very good reason, and I'm delighted to answer it.
Thank you.
I'm going to go back to basic science. When you have B vitamins, you take B vitamins, for example, or you drink a glass of water, or you, and lots of other things, these things are water soluble. They dissolve in water, and you drink them, they go right in your bloodstream. They go into solution in your bloodstream. They travel around your bloodstream, no problem. But there's a difference when you eat something that is basically fat. Mm. You can't have fat globules floating around in your bloodstream. So when you drink olive oil for your salad dressing, it doesn't go right into your bloodstream. It has to be processed to be able to be distributed. Well, let's cut to the ovarian hormones or testicular hormones. They are not water soluble. So when they're coming out of the ovary, that's where they're produced. They can't go right into the bloodstream and just dissolve into it because they're fat. Lipids, they're called, technically, chemistry. So they need special care, special handling. And of course, the design, the miraculous, the astoundingly miraculous design of the human body. Oh my God, want to believe in God got us all that is? Need medicine. Go to medical school. And so how they're handled in the blood is they're bound up to carrier proteins. There's a lot of proteins floating around in the blood. And one of the many, many functions of the proteins is to be carrier vehicles for steroid hormones and for hormones in general. So, for example, when the ovarian estrogen is released from the ovary into the bloodstream, it's immediately picked up by different proteins, a lot of them. The most common one and popular one is sex hormone binding globulin. Oh, I love how so many things in medicine have been named for what they are and what they do. Sex hormone binding globulin. Globulin, you may have heard that term. You may have heard gamma globulin. these are big proteins floating around in the blood. You know that some of them have immune functions. Well, this globulin is a carrier globulin, and it carries sex hormones, and it binds them. Thus the name, sex hormone binding globulin. And this is a big deal. Part of the menopause method, for example, is immediately when a woman shows up for her first consultation, we're going to look at her past blood work, and we're going to see that it's very rare that sex hormone binding globulin has been tested. So we're going to send her to the laboratory to get a sex hormone binding globulins, probably some thyroid and some other testing as well. And because that's part of our absolute mandatory routine, because sex hormone binding globulin can become an issue, and I'll get to that. So there's other serum proteins that carry these hormones, by the way. Serum albumin, extremely prevalent. And other globulins will carry these, the sex hormones as well. But we're going to focus on sex hormone binding globulin. Interestingly enough, although their primary function is to just pick up the hormones at the ovary and distribute them to almost every single cell tissue in the body, because all these steroid hormones are effective in almost every cell in the human body. You tend to think of estrogen as being female related. Well, indeed it is, but it's also brain related, artery related, on and on, bone related, on and on and on. You can hardly name a cell in your body that doesn't love, treasure, and absolutely need estrogen for your whole life. Well, when a young woman, let's say a 20-year-old, is given birth control pills, here the young woman is at the absolute maximum amount of estrogen, progesterone, testosterone, and DHEA coming out of the ovary that she's ever going to have in her whole life. That's the highest level, age 20 plus or minus a couple of years. And then you give this young woman additional estrogen, because in that birth control pill is an estrogen called ethinyl estradiol. Estradiol, the most potent of the estrogens. They always say, well, in small amounts. Yeah, I was always suspicious of that. You're dealing with a young woman who's at the peak of her estrogen output, and you're giving her extra estrogen, and you're able to, along with the progestin, to halt ovulation. Come on now. There is no such thing as light dosages. Yes, there is. I mean, of course, the original birth control pills came in much stronger dosages than current. They've highly refined that. But it ain't like it's a nothing dose. It's capable of preventing ovulation. Come on now.
Right.
So we're dealing with some potency there.
Yeah.
Well, the young woman's body, so to speak, metaphorically goes, wow, we're already floating around with the maximum amount of estrogen, and here comes some more estradiol. Well, no problem. We don't like excessive levels of hormones, so we'll just do a trick to prevent excessive levels. We'll increase the production of sex hormone binding globulin and bind up this extra estradiol, which is what goes on. So in a lot of young women who are taking the birth control pill, their sex hormone binding globulin elevates, binds up the additional estradiol, no problem. Oh, it happens to also bind up testosterone. So a lot of young women in their 20s take the birth control pill and lose their libido, or get diminished libido, because the testosterone is also bound up. Well, wouldn't it make perfect sense that once the birth control pill was stopped, the sex hormone binding globulin would return to normal? Yes, that does make perfect sense, and actually it does not. I've had women who enter menopause with elevated sex hormone binding globulins. The only reason that we can uncover, and it's a common reason, is they took the birth control pill 30 years ago for 1 month or 3 months or 6 months. It doesn't seem to be time-based. It went up and it never came down. No problem. We know how to deal with this stuff, but it's important that we find out about this stuff. Now, that's not addressing your question. Your question is maybe your sex hormone binding globulin is elevated for other reasons. And you named it. You name the reason. If a woman in menopause is given excessive levels of any of these hormones, testosterone, estrogen, the body has a protective mechanism. It will bind up what it considers to be excessive. And in many cases, not all, the sex hormone binding globulin will elevate. And that's one of the downsides of using these robust levels of hormones to treat women in menopause. We advise against it for other reasons. You don't need robust levels. You don't even need youthful levels to get everything we want to have done in menopause elegantly for 10, 20, 30, 40, 50 years. We can get it all done with levels that fall shy of youthful levels. For example, women who have a period and have got usual rich hormone levels, some women need this much estrogen. Some women need higher levels. All of these women, they need this much estrogen to be able to menstruate. In menopause, we've learned that what the women need for treatment of in menopause of estrogen falls just below that amount. And that's enough to protect the vagina and the bones, the arteries, and most everything, not in every single case. Some women need higher dosages, but for most women, it falls right below the amount that a young woman has. Now, back to the questioner. If that sex hormone binding globulin is pushed upwards because of excessive dosages, you'd like to think that when those excessive dosages were rescinded and you got into reasonable levels, that the sex hormone binding globulin would come down all on its sweet own, by its own sweet volition. Doesn't always do that. When I see an elevated sex hormone binding globulin on our initial test in any women, I do not make a big deal out of it. For one thing, it may be slightly elevated or moderately elevated, but never really cause a problem in menopause. That's what really matters. So we just pretend like it's okay. We see the elevated sex hormone binding globulin, no big deal. Let's just continue and see if it causes a problem, because in many instances it doesn't. And we proceed with the menopause treatment with hormones, and the sex hormone binding globulin is not an issue.
See, many women think it's dangerous, dangerous.
No, not dangerous. Let go of the word danger. We're not talking danger here with the elevated sex hormone binding globulin. No danger. It's part of the body's natural protective mechanism. It goes up only to deal with excessive hormone levels. And it's, as far as I know, it is never dangerous. It can present a certain challenge to getting the dosages right. If there's excessive sex hormone binding globulin, it might get excessive binding of the hormones that you're administering, but there is no danger. No, perfectly safe. The most challenging thing about sex hormone binding globulin is occasionally it gets up high enough that it interferes with our dosage.
Yeah, right.
Yeah. So the sex hormone binding globulin is high. We give a certain amount of hormones. It binds up too much of those hormones, so the woman doesn't experience sufficient relieving, replenishing dosages. That's the only issue with sex hormone binding globulin. And we do know how to get it down. And usually it takes a pharmaceutical medication to do it, which is not entirely harmless, but we use it all the time in dosages much, 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 much less than it's used in traditional medicine. It's because the medication we use has a place in traditional medicine, very important place, but we can use it at 1/10 the dosages that they use it for the traditional purposes in endometriosis. So don't worry about it. Forget about it. You got an elevated sex hormone binding globulin. We'll work around it. There's almost always a way. Healing is possible. We figure out these things. And if you got an elevated sex hormone binding globulin, you want to work with someone that really knows what they're doing. Or shall I change that to, if you're in menopause, you really want to find someone who knows what they're doing, because there's hundreds of moving parts like this. And that's why folks like me went to medical school because we found all this stuff fascinating.
Yeah.
And it's, just like some people find auto mechanics, thank God, fascinating, and they get super good at it. And that's where I take my car. I don't work on them myself anymore because I messed up a few automobiles by some of my amateurish rebuilding of the engine activities. Carolyn, if you'll excuse me for 1 minute, I wanted to let everyone know that Dr. Lindsay Berkson is going to interview me on her podcast a week from Thursday at 1 o'clock Eastern Time. Dr. Berkson, is a miracle in the work that we do. And so I still look forward to doing that.
Thank you.
Yeah, I'm going to mention that. It's 1 o'clock on Thursday, the 22nd Eastern Time, July 22nd. So I'll still be doing our interview in the morning, Carolyn.
Right.
Because there's morning and noon where I live. There's such a thing.
I think we have morning and noon here too. Weirdest thing.
Really? You're in California. I didn't know that you guys had morning and noon.
Sometimes we skip the noon, but not often. So we will look forward to Dr. Lindsay Berkson. Are you kidding? And Dr. David Rosensweet together? Amazing. That'll be a nice one. So I would say that would be 10 a.m. Yeah, PST, 1 p.m. EST, and we can all watch. And I would imagine there'll be a playback, but
and maybe Carolyn, you would post the link to Dr. Berkson interview, and if you would be so kind as to contact her if you can.
I will. Yeah. I will absolutely do that today. Because that's you don't want to miss that one.
That's right up your fun alley.
Yeah.
Carolyn Shapiro Joyride.
Yeah, Carolyn Shapiro Joyride. At a city playing near you.
At a city playing near you.
Just bring those cows out and we'll have a good time. Carolyn Shapiro Joy Show. That's a new one. I got to tell Daryl that. He'll be like, interesting. Oh, that's so funny. You're funny, Dr. Rosensweet. Okie dokie. On to number 3. Okay. I am really concerned about my bone, muscle, heart, and health of my brain. Is there a minimum estrogen level that reflects optimal levels for positive health? I've heard so many differing opinions, and there is so much variation about how much estrogen women can use safely that it's seeming to muddy the waters for so many of us. Could you clarify, please?
Yes.
Thank you. Okay, number 4. No.
It's Zany Day on the Funny Farm.
I know, right? I can feel it.
In general, and I'm going to address this first, there is a problem in menopause medicine like no other area in medicine that I personally am aware of.
Yep.
Like you take neurology or you take functional medicine, and that's even the complementary medicine, or you take orthopedic surgery or gynecology or obstetrics or internal medicine. There is such a commonality and uniformity and a standard of care, and most everyone that's out there practicing is abiding by that standard of care, not because there's laws or rules to do so, because it's good medicine. Now, even in any of those fields, you're going to see some minor disagreements. Well, I think this is better than that, or that is better than this, but they are way out at the periphery. There are very rarely major discussions going on in orthopedic surgery, for example, about who's right and who's wrong.
Right.
No.
Right.
It's a miracle. It's beautiful to have a body of knowledge. It's just like working on an automobile. There's not thousands of approaches to working. This is not true in menopause. This is like an infant specialty. It's not even a specialty yet, although Menopause Method is working diligently to create a board certified specialty with standard of care. We already feel like we've developed standard of care. And why in the world did that happen? Because just as specializations were really getting solidified, and they have been since the 70s, 80s, 90s, but the world of treating women in menopause was pretty simplistic back in the 70s, 80s, and 90s. And then in the 80s, along comes bioidentical treatment, and this is getting more sophisticated, including testing, 24-hour urine hormone testing. But, it was in usage by a very, very small number of providers.
Right.
And pharmacists in the 80s, in the 90s. And just as bioidentical hormone treatment, which is so much more detailed, individualized, and sophisticated, was getting going, along comes in 2002 this medical study, the Women's Health Initiative, something I've never seen in the whole history of medicine that I've been around, and I have been around since prehistoric times, I'm pretty sure. And rather you didn't ask me too many questions related to that early history, because it would reveal some real challenges here that I don't want to be responsible to answer for today.
We'll visit that later.
So actually, I've been specializing in treating women in menopause 25 years. I had been treating women for 10 years. When out comes the Women's Health Initiative saying that women were at increased risk for breast cancer, heart attack, and stroke if they were treated with hormones.
Bam! Yeah.
The most interesting thing to me about this particular event, the publication of the Women's Health Initiative, was that it was false. Even in the published study, there was no increased risk. It even has a statement in there that the increased risk with Prempro, not even Premarin, was 1.26, and scientifically that means that there was no increased risk. But it didn't matter. The press got a hold of it and, launched it like a rocket ship, and the general public and all physicians heard only this, that women who were taking hormones were at increased risk for breast cancer, heart attack, and stroke. The whole field of treating women in menopause collapsed at that point. There was 18 million American women being treated with hormones. That's 40% of all American women in menopause, went down to the very low millions, with tremendous adverse consequences to the women who stopped their hormones.
Scared everyone.
It wasn't so much that they stopped their hormones that was the big deal. It was that they weren't taking hormones anymore. So there they go. They're back into vulnerability of bones, arteries, brain, everything, vagina, libido, everything you can name, muscles. And it was a false study. But it gave a body blow to the whole field of treating women in menopause, unlike anything I've ever seen. Well, a few of us, more than a few of us, first of all, we examined the study. We saw that it was statistically insignificant. We said, oh my God, what a tragedy. This is not medicine. This is not science. There's no demonstrated increased risk. And yet they published it as if it was. And I also went to the European literature to talk specifically about bioidentical hormones, and I saw less risk. Even with Premarin, horse urine-derived estrogen, there was less risk. And what does it turn out in the long run? Even with Prempro, the original culprit, there's less risk. And this was the original study committee published this in 2017 in the same journal. The original Women's Health Initiative Study Committee stated, they basically retracted what they said. They said, after 18 years of follow-up, there is no increased risk of breast cancer, heart attack, and stroke, 18 years later. How many people on this planet and how many physicians on this planet have heard that? Oh, very, very small percentage have heard that. And if you want to know the details, we highly recommend a book by childhood friend of Carolyn Shapiro herself, his father, Avram Blooming, a medical doctor, and Carol Tavris, a PhD. Dr. Blooming is an oncologist. So this is his specialty. And it's published, it's a monumental work. It's called Estrogen Matters. Maybe you post it again on the Facebook page. And it totally gives you the details and over 450 references of that women who are treated with hormones, no matter what they are at less risk for breast cancer, heart attack, and stroke than women who are untreated with hormones. Am I, as a man, at risk for cancer or 1,000 other diagnoses? Are you, as a woman, at risk for breast cancer, uterine cancer, ovarian? Yes, you are. We are.
Yeah.
We're even at an increased risk, and there's very special reasons. However, women who are treated with hormones, as a matter of fact, men who are treated with hormones, women who are treated with hormones are at less risk from breast cancer, heart attack, and stroke than women who are not treated with hormones. Men are less risk for prostate cancer if we're treated with testosterone than if we're not. So, oh my God, what a path to answering this question.
It's beautiful, though, really, because that backstory is so important.
So, Carolyn, would you please read me the question again? Because I feel diverted from some of the elements of that question, although I think what I wanted to say there is so relevant.
Well, basically what she's saying, she's concerned about, bone, brain, health, heart, muscle,
yes,
all that.
I remember now.
Yeah.
And here's the news. There is optimal dosages, and you can take too little.
Right.
And you can be treated with too much.
Right.
And the range that's optimal for menopausal women for estrogens, testosterone, DHEA, all of these are super important, and progesterone are well known.
Yes.
In fact, in the menopause method, I've extrapolated from the medical literature and defined an optimal range for estrogens. What's too much and what's too little. Bam, that optimal range is known. As far as I know, that we're currently the only source of assessing that with 24-hour urine hormone testing, what's too little and what's too much. Now, even defining that optimal range, there are exceptions. Mm-hmm. For example, at the low end of that optimal range, what I learned from the medical literature is how much did it take of estrogen to protect the bones in the vagina? This has been studied. It's beautiful work. And it tells us if you got too little, you're not going to protect your bones in your vagina. In fact, there used to be a patch on the market that was 0.014, for example, and they removed it from their market because they realized that that was not sufficient to protect the bones in the vagina. That's the bottom line.
Right.
And also, we know what the upper limit is too, because if too much estrogen, you put a woman at risk for breast glandular cell proliferation, like she does every single cycle when she's young. Well, great. She does it every single cycle when she's young. That's natural and physiologic, but we don't think it's the safest approach to things to get breast glandular cell proliferation, i.e. cellular division, mitosis, in a woman who's in menopause at the midlife mark. So we define the upper and lower limit. Now, having said that, there's always exceptions.
Yeah, oh, yes. Yes, you've made mention of some of those exceptions.
Yeah. What I didn't define at the lower end was how much it takes to protect the brain.
Mm.
Yet there are scientific studies. We teach them in our professional training program. We demonstrate these scientific studies that show in some cases, there's some women who are getting cognitive challenge that they need much higher dosages. Yes, they do. And in fact, I've told this story before. A beloved colleague that I met at the National Academy of Science meeting in Washington, D.C. She sat next to me at a panel, and I went out to lunch with her and her son. She was 65 years old at the time we had lunch. She told me this story. When she was 55, she was practicing physician. and she's starting to have challenges with her memory and her ability to speak, and she's getting cognitive challenges that are so common in women when they start losing their hormones. And unlike a lot of other women, she was staring down the barrel of this, that her mother had dementia and her mother's sister, thus this doctor's aunt, had dementia, both of them. So genetically, she had some vulnerability there, and she's saying to herself, I can't even practice medicine anymore. I'm going to have to quit because I can't keep my head straight.
Right.
Well, she knew that there was a relationship of estrogen to cognitive function. So she started taking estrogen, and she started to get some clearing, and she started to take some more estrogen, and she started to get more clearing, and she started to take more estrogen, and she started to really clear up. And she wound up taking so much estrogen that it was so much that her period returned. And she quit. And we're sitting there at lunch, and this amazing doctor is clear as a bell at 65. We all should think so clearly as she is. So you never say never to more robust dosages. There are reasons, and the questioner asked, well, how much does it take to protect your brain? She had that, the questioner had that in her list. How much does it take to protect your arteries? Well, these are things we always determine, and it really speaks once again to the level of precision, of training, of mentoring, of specialization that your provider has. Because I tell you, for me, 25 years into this, I'm doing what I did in the beginning. I individualize every single patient. And when there's special risks, for example, for cognition or special risks for arteries, we don't rely on the dose level that protects the vagina and the bone. So it's a really nice marker to begin with. We go on and continue to assess in an ongoing way. Yeah, well, how's your brain doing? How's your arteries doing? Is this dosage also protecting your arteries? You have a family history of arteriosclerosis. Are there many factors and many moving parts that lead to hardening the arteries? Are any of them active besides the hormonal protection? So it's just another case of individualization. And that's all it is. And so we do those kind of things. And you want that level of knowledge and experience and training from your provider. And so it takes us back down to, although we do this Facebook Live and many other ways of educating, and it's great fun, it takes you down to your singular job. Viewers, there's one job. Hello from Hong Kong. Oh my goodness.
Oh yeah, she's great.
Hello, hello to you. Our hearts go out to you.
Oh yes, absolutely. She's great.
And it comes down to your singular job as a woman in menopause, from my perspective, or as a man in andropause. There's one job. It's fun to get educated. It's fun to take an active role in your program. Download Happy Healthy Hormones, our book. Give you a lot of information about what menopause is about and good stuff to do. But you have one job. That is, go shopping and find thyself a provider that loves menopause and hormones, has taken the time and energy that it takes to learn a lot about this, to go through rigorous training and mentoring, and is specializing in this. That's what we recommend. That's your job. Go out shopping. Go out until you find one. How will you know? You'll have lots of clues, and you'll trust them. This is what you need. Once you find this provider, that's all you'll go on a journey of synergy and co-creation, and you'll oscillate into your optimal hormone situation based on every single individual factor you got going on. And you'll be tested ultimately, and you'll be monitored year upon year upon year, and you'll have access to really good hormones if they're compounded bioidentical, individualized to you. So that's your job. Go out and find that person, that licensed healthcare provider who can prescribe.
Might take time. It did for me, but I gotta tell you, it was worth every single solitary second of it.
And Carolyn,
I know.
Here we are. It's happened.
Don't say it.
Okay.
Say it isn't so.
Okay. It's so.
Say it isn't so.
It's so.
Let me remind the ladies, Dr. R will send me a link. I can put it up. Dr. Berkson and Dr. Rosensweet together. That's going to be amazing. We will be back on Thursday. I will get with you women who have asked these questions and get with you, and we will ask. And wishing you, Dr. Rosensweet, kind you, a fabulous day. I'll talk with you on Thursday. Justin.
Always a pleasure, and thanks for making it so much fun.
It is fun.
It's so much about our doing it together and who we are together as friends. Yeah, it's a big,
indeed. Oh, from my heart to yours, really, in a big way. God bless everybody. Enjoy. Thank you. And we'll see you on Thursday.